Tomasulo, local family physician here in town, and I used to walk around Sarnas. I just want to touch on one point real quick in terms of the single payer system. We've all been talking about it, and we're worried about it. The truth of the matter is we already live in it. Medicaid, Medicare, TRICARE, it's all a single payer system. And what's happening right now on the family side, or on the physician side of the house is, and the ACA kind of exploited that over the last 5 years, is the transition into the Medicaid world, which is also just a single payer system. So what's happened on the physician's side of the fence, Medicaid didn't reimburse very well to begin with. Once it kind of pushed everybody into the Medicaid system that was now qualifying for Medicaid, it changed the reimbursement rates, and we were already overwhelmed as physicians seeing 30, 35 patients a day, that now that you brought a whole new pool of applicants into the healthcare platform and there was no reimbursement increases or changes, physicians started to retract out of the Medicaid system. So we stopped accepting Medicaid patients, we stopped accepting Medicare patients, and unfortunately TRICARE is lumped into that process as well. And I'm one of those individuals. So what I can say is, the healthcare system is fundamentally broken. It's been broken for a very long time. Probably the last 5 or 10 years, it's really been exploited. We're in the 5th year now of the ACA, and it's really starting to drive the needle home in terms of what healthcare looks like in the United States. And it's not kind of on this great track record. I'll tell you, though, we can go on in days about the dysfunction of healthcare, from the physician standpoint as well as the patient standpoint. What I think we need to start looking at are solutions. How do we fix the problem? What we're trying to talk about, and I think what I was brought here for, is kind of this direct pay model of practice, or direct primary care model of practice, a couple different ways to think about it, but it's truly about a cash-based practice. Retracting out of the insurance world, retracting out of the current system that we live in, from the insurance companies kind of mandating what we're able to charge for a visit and then get paid and reimbursed. So the example was, here's your $4,000 bill, we'll give you $400. You change that on the family physician side of that fence, and it really becomes an economic problem, in the sense that the traditional family physician on an office visit, somewhere around $100, $120 nationwide. That same visit for a sore throat in your urgent care is about $1,500. That same visit inside the ER, it's about 3,000 visits. When you take the Medicaid patient and you now increase that pool, family physicians are not accepting new Medicaid patients. The only place that they can go are hospital-based institutions for the most part. So instead of going into a primary care physician, they go into the urgent care. It's $1,500, and that's our money. $3,000, that's our money as well in terms of taxpayers. So you can see very quickly, it doesn't make economic sense to create family practice clinics. So you start seeing a transition of urgent cares popping up, freestanding ERs popping up, and then how do we start affiliating those with the hospital, because truly that's where all the money is being wasted, I think, or a big portion of it. So you start seeing the first choice ERs, now they're branded with the Memorial UC department. It's an economic process. So what we're doing, there's a small group of physicians across the country that are moving into direct pay practices, and what we've done is unplugged ourselves from the traditional type of model of care. We don't accept insurance, we have nothing to do with insurance, we're trying to be extremely transparent with how we practice medicine, and more importantly, some people are going to get offended by what I say, it's not about the patient. This is about doctor satisfaction. We have to start rethinking the way healthcare is actually being looked at. Patient satisfaction and quality, I know that's been mentioned a couple of times, those are byproducts of the interaction between the patient and the physician. And I think if you give the physician the time that they need to manage patients in an appropriate manner, quality and patient satisfaction is going to go through the roof. Our practices, we have about 99.8% patient satisfaction. It's almost unheard of, but that's just what the numbers are. The way that works right now in terms of economics, family medicine over the last 5 years have seen flat increases in terms of insurance reimbursements. So what happens with inflation, we have to see more patients in order to maintain our overhead and our expenses. So we've gone from maybe 15 or 20 years ago seeing 10 or 15 patients a day, which was very manageable. You got quality care. You knew who your doctor was. If you went to him 10 times, you saw the same doctor 10 times. You didn't see 10 different physicians. So what's happened since that transition over the last couple of years is you have to see more patients in a day. So instead of seeing 15 or 20 patients, now we're seeing 30 patients. We're at the point where you're seeing about 35 patients. National averages for family physicians, their panels are about 3,000 patients per doctor. The economics of that is 1 per 100 per day is what you see in the clinic. So if I have 3,000 patients on my panel, I see 30 patients a day. And then if you need acute care visits, sore throats, if you have a urinary tract infection, something else is going on, you have to be seen, I can't really squeeze you into the clinic in a traditional setting. So off you go to the urgent care, the ERs. In order to kind of change that whole process, you have to kind of redefine and restructure what healthcare is. You have to eliminate what the dysfunction is before you start trying to fix the dysfunctional system. And unfortunately, I think for family medicine, which accounts for about 85 to 90% of everything that you ever experience, that has to be restructured from the ground up. We can't fix it anymore. So in the direct care type of clinics, we pull completely out of the insurance equation. We deliver the product directly to the consumers, and all of us are consumers of healthcare. The Affordable Care Act and these high deductible healthcare plans have made you more of a consumer of healthcare because now you're paying your premiums. Every time you go to see the physician, it's a higher cost, you have a higher copay, and it's a higher out-of-pocket expense, which actually prevents healthcare. Because now you don't want to go to the doctor because it costs more than what you've already paid. So for us, getting out of the insurance world, we have a flat rate. It's pretty affordable. I mean, children are $35 a month, something like that. Adults, less than $60, $70 a month. Depends on what practice you're looking at nationwide. But what we do is we change our ratios of doctor and patients. We only have about 700 patients per doctor. So that equates to about 6 to 10 patients per day. So now you're actually able to spend half an hour with patients, an hour with patients, and really start managing the care. We don't refer patients outside of the system unless they absolutely need to see specialists. We try to do as much as we can inside of those clinics, and then we start leveraging our medical license in terms of spending your dollar a little bit more cost effective. So putting pharmacies in the clinic, putting lab services in the clinic. You know, great examples are if you come into the clinic and you think you might have strep, get a strep test. I can give you a prescription. If it's positive, I can fax it to the pharmacy for you. It takes 45 minutes for you to drive over there and get your medication, and maybe you pay $15 for that prescription. That same prescription inside of these types of practices, it's about $2 to $3, to be quite honest with you. Market-on medications, sometimes 6, 7, 800% is pretty common. Labs are the same way. We choose not to make the economics of healthcare and the profitability of the company based off of medications and laboratory services. Those are just things that you're paying for, so we're going to try to help navigate that process. There's not a lot of clinics like this across the country, maybe 4,000 of them, but they're grabbing a lot of national attention. You know, the American Academy of Family Physicians, the American Academy of Physicians, American Osteopathic Association, the AMA, all have recognized these types of practices. Probably the solution in terms of primary care, which accounts for about 85% of everything that you have in your life, as the solution to try to get us out of the problem that we're in healthcare. The bigger equation is or I should say, the direct primary care clinics are really simple to understand. It's a patient, it's a doctor. It's about the doctor, to be quite honest with you, because I need to be able to do this until I'm 80 or 90 or until I want to tap out at that point. So it's about us providing care to you in a platform that accommodates your schedule. So we do it on a 24-hour basis, 7 days a week for patients. Very, very simplistic. We keep you out of the urgent cares 100% of the time. The ERs, we go back to using the ERs for what they were, life, limb, and eyesight type of equations. If you need stitches at 10 o'clock at night, you call your doctor, let him tell you whether you need stitches or not. Send you in the clinic at 10:30 at night, stitch your fingers up, and there's no cost to that in addition to what you've already paid. It's extremely simple. For me to pay for a package of sutures, it costs about $8. That same suture kit in the ER is about $2,300. You pick where you want to pay. I can care less. It's your money, right? So, and it's my money too, because I pay for those services as well. The difference is you would be astounded by the waste that's associated with healthcare spend. And it doesn't take a genius to really look at the large buildings and figure out how much overhead it takes to maintain that building. Hence, over the last 5 years, just in our community alone, you've seen that all of these private companies or independent practices have been bought up by either Memorial or Centura for the simple purpose of trying to lock up the downstream revenue that's associated with that practice. So So if you have a family practice group that's independent and the hospital is getting all the referrals from that family physician, wouldn't it make sense for the hospital to own that family physician? Because now they're going to refer them to me, the hospital, not our competitor across the street. That seemed to be a great concept. It's failing miserably because family physicians or doctors in general were not very good factory workers, and that's kind of what we've been equated to over the last 10 years is truly a mechanized family institutional practice of medicine, which is not where physicians really want to live. So for us, really what we want to try to do is reestablish what the doctor-patient relationship looks like, reestablish what the cost of true care is, and be extremely transparent in that transaction. Allow the patient, the consumer of healthcare, to start making some informed decisions. Personally, I don't care where you spend your money. It's your money. My job as a doctor is to educate you on choices. There's this choice and there's this choice. And just because you don't want to take your insulin and you're diabetic doesn't mean I'm going to kick you out of my practice. We're just going to have to figure out how to keep you alive from the complications of your disease that's going to happen regardless if I do something for you or not. But you find when we have time to actually talk about those conversations or those topics and diagnoses that you're much more likely to listen to what I have to say, or the physician. You're not kind of this cowherd mentality. We see 45 patients or 30 patients. We spend 8 or 10 minutes with a patient, and out of that 8 or 10 minute conversation, you're supposed to understand everything that just happened, let alone your complaints that you came in with. We just have to restructure how that works. I can tell you a great example of the waste in healthcare, or the way that it's sold to the public, is really these $4 prescriptions. It's a great example. Walmart, Target, everybody has $4 prescriptions. When that came out, it was a phenomenal process because you're used to paying $20 for that prescription. Well, now it's $4. But when you realize that medication costs about 38 cents, your $4 prescription, the margin, if I could create a company and have that kind of margin, I wouldn't be here anymore. I would be off somewhere in Tahiti enjoying life. It's those margins, they don't exist. Big pharma, that's a real margin. So for us, we're not able to buy the prescription for 30 cents, but maybe we buy it for $1.50 and we sell it for $2 to cover our 30-cent transaction fee and a 3% swipe fee. But the point is you don't have to be greedy in this country, especially in healthcare. So we just need to start rethinking on how we consume healthcare. I think even if you're in a high deductible health plan, you have to advocate for yourself as being a cash-paying patient because it's your money, it's your deductible. And you'll find that when you're a cash-paying patient, you can actually start leveraging that tremendously. To the degree that if you need a chest x-ray inside of our clinic, I can literally send you a quarter mile to the hospital, that chest x-ray, after your 30% discount. If you pay within 30 days, it's $486. That's what it costs. I can send you 3 miles down the street and we can get the same one for $50. I'll tell you where to go. It's that type of mentality that you have to start looking at from a consumer's perspective, which is healthcare is no different than buying cars, books, insurance, or anything else. You have to be educated about the system. So I think that's probably